And welcome to the 100th episode of McGill Cares webcast series. I am so excited that this day is here. And I am going to be joined by my wonderful colleagues, Dr. José Morais, Dr. Pedro Rosa-Neto, and Dr. Serge Gauthier, who are going to be answering a lot of your questions. I would like to really begin by thanking some of the very generous donors that made it possible for McGill Cares to exist. The McGill Cares is part of the McGill University Dementia Education Program, which is funded by private donations, and many people have contributed to the success of the McGill Cares webcast series. So as I mentioned, today's we're going to be talking about Ask the Expert. Many people have sent in many frequently asked questions. So we will be I will be talking to the doctors, and we will be discussing a lot of the points that you have asked us. But before I begin, I would really like to provide everyone with an overview of the comprehensive programs that we have developed when this program was founded in 2017 that are all there to support persons living with dementia, family and informal care partners, healthcare professionals, medical students, and the public at large. And I founded this program because of my own personal experience caring for my mother who had Alzheimer's disease, and for which, unfortunately, I never received any type of information or education. And it's knowledge on this journey is really the most powerful resource. And so, I was extremely fortunate to be working with McGill University, and I had no prior affiliation, but I knew that, we had one of the best medical schools, not only in the country, but in the world, and who were willing to work and partner with me to help create these amazing resources. And how fortunate I was that McGill assigned some of the best healthcare professionals in our province, if not our country, to work with me on this. So I just wanted to take a moment to, as you know, you're watching today because you're obviously a viewer of McGill Cares. And this is the 100th episode. McGill Cares began in May of 2020. And I just wanted to let you know that you can access all of the previous webcasts on our website. So if you go to our website at mcgill.ca/dementia and you click on McGill Cares webcasts, you will see a section that says McGill Cares Archives. And then all you need to do is go and search according to the different topics. They're all listed there. All of the webcasts are available on YouTube, so you can watch on demand. So I encourage you, please, to go back and see some of the many incredible webcasts that we have recorded. And just for some information, here are some of the most viewed ones that have taken place. The 10 most viewed ones since 2020, Understanding Lewy Body Dementia, End of Care Life, Activities to Engage a Person with Advanced Dementia. We have done webcasts in French as well. Interview with the founder of the Montreal Cognitive Assessment, Understanding Responsive or Challenging Behaviors, Understanding Vascular Dementia, Frontal temporal dementia, Understanding dementia as a whole, and how alcohol affects cognitive and cardiovascular health are some of the most watched ones. And when I go back, from the very beginning, I've had some amazing guests, persons living with dementia, including Roger Marple, who unfortunately recently passed away. I met with people from the LGBTQ plus community. I've had an interview with Tifa Snow, who's very famous. She's the dementia care consultant in the US who's helping Bruce Willis and his family navigate their journey. Andre Picard, a famous the Globe and Mail journalist. One of my first webcasts was in my bedroom with my spin bike behind, where I interviewed a former care partner. And I even came and talked about, the correlation between cardiovascular illness and the impact it has that it's had on my own life and my journey with having multiple pacemakers with Dr. Jacqueline Josa. And my guests today have been part of this webcast series from the very beginning. Dr. Morais, Dr. Gauthier, and Dr. Rosa-Neto have been part of this program from the very beginning. And when I look back, I'm so fortunate to have them as part of our team. So in addition to the webcast, as I mentioned normally, we have this incredible resource. It's called the Dementia Your Companion Guide. It's now available in 10 different languages with many more to come. You can download it for free, or printed copies are available on Amazon, and all proceeds go to support our program. So that's one of our other very important initiatives. And in this book and guide, you will find all kinds of information relating to the illness, how to keep somebody safe, how to help them manage their activities of daily living, how to, again, the aspects that could occur as the disease progresses. So please have a look at this very important guide. Our team is also very proud to have been the lead authors of the 2021 and 2022 World Alzheimer's Reports. It was Dr. Serge Gauthier, who was our quarterback and brought us all together to write these world reports. They are probably some of the most comprehensive resources ever written in the field of diagnosis and post-diagnostic management of Alzheimer's disease and other related dementias. These reports can also be found on our website or on the Alzheimer's Disease International website. While we started off with a lot of education, the public reached out to us and asked us that they really wanted us to put together some programs to support care partners. So we work in collaboration with the McGill School of Social Work. We have two amazing pioneer social workers, Lucy Baralek and Joanne Besnert, who lead Caring Conversations. So please, that it's a educational and supportive program that you can register for. They take place every month, all virtual. And we also work in collaboration with the Alzheimer's Society of Montreal to provide support groups for spouses and for the children of people living with dementia, available in English and French. You can also register for that as well. And this year we are proud to have launched, in collaboration with the McGill University Research Center for Studies in Aging, a new support group for young carers. So I also encourage you to go and have a look at that program on our website. And another important resource is the Dementia Activity Booklet, which has all kinds of recreational and leisure activities, over 40 of them, to help encourage a person living with dementia to participate in life, to stay active, things that you can do with spouses, with grandchildren. We are now working on a project to make these activities come alive through video capsules. So stay tuned for that. And again, that booklet can be downloaded for free in English and French. And finally, one of our last programs, which will be launched in 2024, is the Total e-learning, which will be an online education program for caregivers. So we look forward to announcing that in 2024. I also would just like to thank my wonderful team members, Maria Vincelli and Diane Wiedner, for all of their support in making McGill Cares a reality. And I also must thank the super duper duo team of Stuart McCombie and Jonathan Roy from the McGill Multimedia Live Events Department, because that is why I'm able to come to you in your homes, thanks to these guys who made this happen. So now I would like to introduce the members of my wonderful colleagues who will be answering the questions. I would like to begin by introducing Dr. José Morais. He is the director of geriatric medicine at the McGill Faculty of Medicine and Health Sciences and the McGill University Health Center, and he is the co-academic and medical director of the McGill University Dementia Education Program. Next, I have Dr. Serge Gauthier. He is a clinical neurologist specializing in the development of new tools for diagnosis and treatments for people living with Alzheimer's disease. He's a world-renowned neurologist, and he is the other co-academic medical director of the McGill University Dementia Education Program. And we have our amazing colleague, Dr. Pedro Rosa-Neto, who is the director of the McGill University Research Center for Studies in Aging. He is a professor of neurology at McGill University and a clinical neurologist with expertise in the quantification of dementia pathophysiology and preclinical diagnosis of Alzheimer's disease using biomarkers. Welcome to the 100th episode of McGill Cares.
Congratulations, Claire. Very pleased to be here to share this moment. 100 episodes is something. Congratulations.
Thank you. Well, I'm so happy to have you all here with me. And we thought that what we would do is have an episode called Ask the Experts. We invited our viewers to send in some questions, and as I look at them, they are definitely the most frequently asked questions. So I'm going to begin with you, Dr. Morais. And the first question is, why is it so important to have an official diagnosis?
Yes, I can answer that, and I will invite my colleagues also to add further information. But many families, when they come to the office with their loved one because of memory issues, they really are at loss what they observe, because with the memory loss is some difficulties in functioning as usual. There's a lot of stress going on. And just by informing them of the diagnosis when we confirmed it's the case, it procures them a big relief, and the families as well as the patient have the right to know what is going on. So this is a first needed step, because it leads to many other consequences. Even if there is not a cure, we can do a lot of preventive approaches to deal with the major demands that the disease imposes in family relationships and decisions to take for the future. And this is an opportunity to review then what can be done to protect them from further future difficulties. I'm just giving an example, such as having a will with a mandate being done, explaining some changes in behavior and personality that they have observed, procures them a lot of reassurance, a lot of acceptance needed to continue to the journey associated with the disease. Yeah.
So, Dr. Rosa-Neto, what is the process to diagnose the different types of dementia? Some family members insist on having a brain scan. Does having a scan provide useful information for treatment? Is that really necessary?
That's a very important question. I think the process of the diagnosis change a little bit from based on the patient. For example, if the patient is a young case, is a person that younger than 65 years old, I think it's very reasonable to evaluate this person thoroughly. And this includes not only a scan, but also a very nice clinical history, genetic history, neurological examinations. And we have to do the basics, ruling out possible causes of reversible changes in cognition. And then after that, we come up with a list of possible diagnoses. And I think the scans today are part of this investigation. So scans like MRI, they serve to rule out the presence of tumors, severe vascular disease, and with advent of disease-modifying therapies that are coming soon to Canada, we need to understand the presence of protein aggregations that are amenable of pharmacological interventions. As Dr. Morais was telling before, the diagnosis is important for various reasons, but on the verge of having a disease-modifying intervention arrive in Canada, I think the diagnosis also is fundamental for therapy and management. So pretty soon we will be using biomarkers to identify the presence of protein aggregation, especially in the case of Alzheimer's disease. And if a person qualifies for undergoing these types of interventions, I think this is going to be frequent and applicable to every single individual. Of course, when the patient arrives with a very clear clinical syndrome, and the patient, has already more than 65 years old, I think we don't need actually to spend a lot of resources, and we'll have to devote is much more on the management of these cases. But when the diagnosis is not clear, I think this use of biomarkers, and especially scans, I think, play a fundamental role in order to ascertain a clear diagnosis and allow us guide the family to the journey of management for these individuals.
So the role of the family member as well plays a very important part of the diagnosis, because you really depend on the families arriving with clear symptoms, right? I mean, because like Dr. Gauthier in the 2021 World Alzheimer's report, you were saying what an important role the family members play in terms of you getting that feedback from them, because an assessment is not only, I'm supposing, your biomarkers you scan, but it's what the families are going to be relaying to you, correct?
Absolutely, absolutely. So the role of the family member comes from the day zero. So this is they provide us a kind of an independent assessment of the patient function. So we call it and this type of a report, it's very important in order to contrast what the patient is reporting to us. So it's important also to bear in mind that for the next steps, because this is a progressive chronic disease, the presence of the family is extremely important for the management. So it's important for the diagnosis and also important for the therapeutic management of the case.
Dr. Gauthier, in your career, you've seen probably thousands of patients. And what are the next steps? Like, once you disclose a diagnosis, what are the next steps that you normally recommend to the patient and the family?
Thank you for the question. And indeed, we sort of addressed that topic at length in the second World Alzheimer's Report 2022. And the short answer is education. So answer the questions truthfully, unless there's a risk of catastrophic reaction, which is rare. Education is not going to happen in 5 minutes, so there has to be steps taken so the person with symptoms and the family members or friends that come with that person either give you feedback from that first interview about disclosure and I use emails, frankly, throughout my career, and it was one way to interact with people. I could even keep their message and my replies on file, so it was a complement to the visits. My hope is that for the future, we will have a contact person at every clinic or office where people are seen with the diagnosis of dementia, a bit like what we do for diabetes, some types of cancers. There has to be a contact person that will help with the education and then follow people because their needs will change over time. There are various stages in these conditions. Alzheimer's disease is the best known and perhaps the best characterized in terms of progression. And there'll be some excitement in the near future when we have new treatments that will modify the progression. And we will learn together how much we delay progression to the next stage of disease.
Dr. Morais, under what circumstances would you not feel comfortable disclosing a diagnosis? Like, what would be some signals that maybe I shouldn't tell this person?
I mean, sometimes it happens that in one single interview, visit, examination, we still do not possess a diagnosis. So this being the case, we shouldn't be conveying message that we don't have certainty on the condition the patient is presenting. As we will accumulate more evidences through results of investigations we have requested, those mentioned by my colleagues here, then we are certain the diagnosis and we feel more confident telling them what we think is going on. It's the first needed answer to your question. There is also sometimes when the person still capable of understanding what is happening to him, a danger of having a catastrophic reaction already mentioned, or in the case of severe depression, we have to be more careful and not step in with a diagnosis that we are not sure either, so that eventually as you develop a relationship with the patient and the family, it can become easier than to make them disclose the diagnosis. Voila. This is what I want to say. Maybe Dr. Gauthier could add a few more pieces of information. Yeah.
Just a word of wisdom that the diagnosis will change over time, and we should be honest. If we're not sure what is the nature of the syndrome, is it dementia or before that stage, mild cognitive impairment? And even in persons who have what looks like Alzheimer, over 2-3 years, they may change into something that looks more like Parkinson. And we have to be honest and say, at this point in time, with the information available, it looks like this condition at this particular stage, but we will together manage this and see how things evolve. With the availability of biomarkers that Dr. Rosa-Neto already mentioned, including blood tests that are around the corner, spinal fluid examination, which are available, and specialized scans of the brain, we may be able to be more accurate in the early diagnosis. And this is a new challenge we will have. I don't know if Pedro wants to say a word about that. He sees a lot of young people in their 50s, 60s, who may have a diagnosis of Alzheimer with minimal symptoms, but it's a biologic diagnosis. So this will change the way we talk to people. And the good side of that story is that there will be treatment available if the diagnosis is made so early.
You're making me.
If I may, we can even consider a window of opportunity to do some prevention, by controlling risk factors that can still have an impact on the disease progression, as opposed to have a late diagnosis in which there is less a chance to do prevention.
So how many times a year then should a family member expect to go and have a follow-up? Because I'm listening to, it's as it changes over time. Should a family member, should they go once a year to see the doctor, twice a year? Like, how often should they come and see you?
Pedro?
So I think after the diagnosis, usually the diagnosis takes about minimum 2 visits, right? So the first visit, we do the initial assessments and we order some tests. And the second visit will wrap up with the patients. And usually it happens 3 months after the initial visit. So the idea is to, each case has their own complexity. You have to appreciate the clinical status of the patients, the comorbidities, and to try to optimize the therapy for these individuals. Sometimes the patients present some side effects, and you have to correct for that. You have to change the medication. And usually the first year, I think probably you have 2 or 3 visits. And the subsequent year, I think it's reasonable to see the patients once per year. And the reason for that is that the development of the disease is slow. So we expect actually to have, probably a decline on the metrics like the Mini-Mental and MoCA about 3 points every 18 months. So this is why we think it's reasonable to see patients every 18 months. So we have to renew the medications. You have to reassess whether we can improve any specific aspect of the disease. We have to inform the family, and I think this time frame for me is ideal.
So Dr. Morais, like, as the disease evolves, it's going to impact a person's ability to manage their finances as well as to drive. Do you agree that it really should be the role of the doctor to inform the patient that the time has come for them to no longer be, like, that they should have assistance with managing their finances as well as no longer be able to drive?
Yes, I mean, these are important aspects of safety, driving, safety at the home as well, to prevent accidents, etc. So, in fact, the society has given the doctors a lot of power to intervene about driving. And we are bound to notify our Assurance Automobile du Québec about the safety of driving. And I tell my patients, unfortunately, when I see that they are reaching a level where judgment or reaction time is difficult, that I have to notify And it's never a happy thing to say nor to accept from the patient perspective. But I tell them, look, if you feel that you are still safe to drive, then the SAAQ will ask you to undergo a driving test, and we'll take it from there. But until you receive the notification to go to a driving test, you should not be driving. And one indication that it is true that they should not be driving is when family members, their loved ones saying, oh, I don't feel comfortable having him driving besides me because I think he's sometimes at loss where to go or how to react. And before a catastrophe takes place, it's better to stop driving. Yeah.
All right, let's move on to now the topic of genetic risk. This question comes up all the time. So Dr. Rosa-Neto,
Okay.
if I have a sibling who was diagnosed with mild cognitive impairment before the age of 65, am I or other members of the family at increased risk of developing dementia?
Right. So this is a very important question because it comes from the original initial assessment of the patients. I think family history is something that's extremely important to be taken. The family history provides, in conjunction with the clinical syndrome of the patient, tell us about the risk that other family members are somehow undergoing. In case of one family member affected, there is an increase of risk of Alzheimer's disease. And if there is 2 individuals affected, the risk can go up to some studies from 20 to 30% more. So we know that there are some genetic factors that can affect the probability or the risk to develop dementia. There are about 70 genes that are associated with this type of increased risk. The most important one is called apoprotein E4. It's a gene that Dr. Gauthier has, with Dr. Gauthier has described kind of 2 decades ago, and this constitutes the most important risk factors. In Quebec, about 13% of the individual of the population carries this gene. So in patients that have the diagnosis of Alzheimer's disease, about 45% of them carry these genetic risk factors. It's very important to understand that this is not necessarily deterministic. It means that if you have this gene alteration, this gene polymorphism, it doesn't mean that you will have developed dementia. And in fact, if you take prevention studies like the finger studies, you can see that the carriers of these genetic alterations are the ones that better respond to the interventions with exercise and interventions on the level of nutrition. So there are other genes that are associated with Alzheimer's disease, and they are much more severe. So there are genes that are associated with the metabolism of a protein called APP, amyloid precursor protein, which we believe today that is the culprit of Alzheimer's disease. So the APP gene is located in the chromosome 21, and there is another enzyme that cleaves this protein in the cell membrane called presenilin, and the presenilin is produced by 2 genes, the gene PS1 and the gene PS2, located in the chromosome 14 and the chromosome 1. And if the individual is carrier of these genetic mutations, the chance to develop Alzheimer's disease is so there is 50% of the probability of inheritance for inheriting these genes for an affected parent. So in this specific case, the dementia starts very early. Sometimes, 40 to 50 years old, develops relatively fast and develops with some atypical features. So in these specific cases, we need to, and the load of patients affected in the family is about 50%. So this is a very particular case, which constitutes about 1% of the patients that we see in the specialized clinics. So in relationship to the other genes, I think what the good news to know is that they impose a risk that can be modified by adoption of health lifestyles, and I think this is extremely important to understand. So, but coming back to the question, the risk is increased. The higher the load in the family of persons affected, the higher the risk of developing the disease. It's present, and it can reach up to 30%, according to some studies.
Thank you for that. So actually, that's a good segue into my next question for Dr. Gauthier with regards to treatment. So the question is, there's 2 new drugs that are currently available in the USA, and I'll say in the US, to treat dementia. Can you explain how they work and what types of dementia do they treat? Now, I must say that Dr. Gauthier and I recently did a McGill Cares webcast just on this topic. So if you want to have more details, I really encourage people to go and watch that.
Well, the short answer to this complex question is indeed there is a new generation of medication. They are monoclonal antibodies. So they're kind of small proteins. They're given intravenously or subcutaneously. About 1 or 2% of what you inject gets into the brain, and they tag on to the amyloid protein that Dr. Rosa-Neto mentioned. And within a year, essentially all the toxic amyloid is cleared out of your brain with those monthly or every two weeks injections. And after 18 months, there is a slowing of progression of disease that we can easily measure clinically. The debate is whether the effect size, how much difference, like 3 to 6 months in a study of 18 months, is that sufficient to justify the infusions every month or twice a month? The cost, it's about $26,000 US per year. And the risk of brain swelling, which is a manageable risk, but still it requires serial MRIs. It's not holy water. This is a first generation of disease-modifying drugs, and we expect others to follow closely in time. One will be oral instead of injections and free of the brain swelling risk. Then there'll be other medications that will tag on to other parts of the Alzheimer puzzle. Tau protein buildup, maybe neuroinflammation, maybe some way the brain is handling sugar, glucose metabolism. It's going to get progressively, in a way, more complex, but more personalized treatment. So it's a time to have cautious optimism. And what you do mention, the 2 drugs available in the US are being considered by Health Canada. And we are preparing in Canada and Quebec in particular, if these drugs are approved in a year, can we use them for the right patients? And just to finish on that point, this would be people who have Alzheimer's disease at a mild stage, who have evidence of amyloid in their brain. So this will require a spinal tap or a scan of their brain. This treatment would be a minimum of 18 months, possibly 2 years, possibly 3 years, and then the treatment would stop because you would progress, although at a slower pace. And hopefully by that time, we will have the next stage of treatment. It's a bit like chemotherapy in the early days. There was a first wave of treatment, then you're in remission, then there will be a second wave of treatment still under development.
And this goes back to my first question about the importance of seeking a diagnosis as soon as possible, right? As early as possible, because these treatments only work at the very beginning. So the earlier you're able to identify the symptoms and be able to bring in this treatment, the better, right? Because if people are already in an advanced stage or even in the medium stage, it becomes more difficult, correct?
Yes, but even without these drugs being available, an accurate diagnosis is important to plan for your future. You may be 65 and mild cognitive impairment due to Alzheimer's disease. Okay, I'm going to take maybe early retirement and I'm going to do my tour du monde that I was planning for now instead of waiting another 5 years. People will also have time to plan in terms of will making, advanced care planning, etc.
Dr. Morais, I'm going to go into now the topic of caregiving. Okay, so you see a lot of older adult care partners in your clinic. Like, how can people recognize their own boundaries, when it comes to taking care of a person? Like, at what point do you recommend that they should seek additional care at home? Like, what do you see symptoms of burnout in a lot of the care partners?
Of course we do, unfortunately, because the disease progresses and the demands on care also increases. The changes in personality of the person that is happening because of brain changes. All of this imposes a lot of stress to the family member that is the closest to the patient, the care partner. And they reach a point where because they want to do good and they get more and more implicated in the care, and they can feel helpless and discouraged and anxious because they should face that disease not alone, but also with the help of the community services available, indeed, to prevent that they reach a stage where they feel burnt out. So it is important that the caregiver is aware of what is available in the community to come in support of the management and all the care needed for the disease. And one has to recognize that we are not robots, that you are not Superman or Superwoman. And when they start feeling these sensations of being inadequate, of feeling overwhelmed, of feeling helpless, they should look for help and support, because otherwise, as I used to say, I end up having 2 patients instead of 1, and it's never good.
Would you say that men have a harder time in terms of admitting that they're exhausted or that they're feeling depressed? I mean, I'm thinking of the month of November now and, awareness on mental health with regards to it. Do you think men would have a harder time?
It's a recognized phenomenon. It's part of our genetic makeup, partially due to culture that pushes men to feel that they are the strongest, to feel that they should never manifest their weaknesses. But there is nothing wrong to recognize our own limitations. And yes, we can feel overwhelmed with such disease progression and demands that it imposes in the family, for example. And there is only one way. I mean, not one way. There is, to my understanding, 2 major ways of solving the burnout. One is to increase knowledge of the disease. It is why the mission of the Dementia Education Program is so important. And the second is to understand that disease is so complex. There's so many angles of the person, the family life, the implications on finances, etc., that they should not be facing this alone. Every caregiver, care partner should have someone with whom he can talk about what is happening, know about support that is available. And this is the way to navigate the disease, the management of the condition in a healthy way, as opposed to feel isolated, burnt out, over distressed, and which is a catastrophe both for the person as well as for the patient, right?
So we receive oftentimes a lot of questions around medication management. The disease brings with it, symptoms that could provide sometimes what we call responsive or challenging behaviors, where a person becomes very anxious, they could become depressed, there could be hallucinations, paranoia. I'm going to throw this out to the 3 of you. What are some of the most prescribed medications that you in your practices have worked with?
If I may, I would say that none of the medications, except for some very specific manifestations, such as depression, let's say, are a perfect answer to the problems that patients manifest, you know. And before even thinking about medications, is there anything in the house, in the relationship, that can be done so to diminished, to control the so-called behavior difficulties, you know? I give you an example. As a person progresses in the disease and becomes less capable of taking a shower or a bath, you know, if that person all of his life was used to take a bath or a shower by the end of the day, trying to make it taking place early in the morning causes too much stress to the person. So we have to somehow adapt to the modes of living of the patient so that it will trigger less anxiety, create less agitation, and it is only after we are sure this has failed that we can consider some medication, and use with precaution, because medications carry its own side effects. So start low and go slow is the device we use in geriatrics with some of the medications. And I can allow my colleagues to also bring their expertise on this topic. Yeah.
Maybe I'll just say a word before Pedro adds his own experience. But for the past 20 years, we've had the good fortune to have in Quebec, reimbursed by the RAMQ, medications that increase brain acetylcholine content. And these are called donepezil, rivastigmine, galantamine. And most patients with early dementia, whether it's Alzheimer or mixed dementia, will have a chance to try them. And at least half of people find it is helpful in sometimes subtle ways, like initiative is back to do things they gave up on in their routine at home. There's also, if you take these acetylcholine enhancing drugs over 1 or 2 years, there's some evidence you delay emergence of what you call troublesome behaviors. And so that's another unexpected good effect of these treatments. So as José quite rightly say, medications are not the solution that you should always think of, but there is at least one kind of specific medicine for dementia that we have experience with, and they're available and they're reimbursed. They're available as pills or patch, transdermal patches. And I would say most people in Quebec have a chance to try them. And as Pedro was saying, side effects are manageable over the first 3 to 6 months, and then it's once a year follow-up. And probably most people on these medicines are able to take them for 3 to 4 years with not a lot of progression in their symptoms, and maybe delaying emergence of troublesome behaviors. I don't know if Pedro shared that experience, even if you're younger than me.
Yeah, absolutely, and I think it's extremely important to understand that the disease is a continuing, and I think what José was referring to is when the patients are in the most advanced stage. So they start to present a lot of anxiety and a lot of agitation. And I totally agree with what he was saying, and also agree with what you just posed, Dr. Gauthier. What I think it's important is that to bear in mind that these patients, they have difficulty to express themselves verbally. Sometimes they feel pain, and sometimes there is something that is extremely, bothersome to them. And I think that it's very important from the part of the healthcare provider and also from the family to try to identify obvious causes of exacerbation of anxiety that can be easily manageable. And of course, when the disease, there are some cases where you have extreme problems associated with agitation, and this requires actually an expert management.
So let's talk about anosognosia. I learned that word, anosognosia, or the loss of insight, and how that could impact not only the person living with dementia, but their care partners, because a person suffering from anosognosia will refuse to go and even be tested. So maybe you all could say a few words Dr. Gauthier, especially with regards to, you know, somebody, how it affects even conspiracy theories, for example.
So anosognosia refers to the inability for the person, usually with Alzheimer's disease, to recognize that there is a loss of autonomy and capacity. And this will delay going to the doctor for a diagnosis. And even after a diagnosis, there may be denial that there is a problem. Yeah, it's common in Alzheimer's disease. Sometimes it's better than having too much insight and have so much anxiety because you're too aware of what's happening. And so the two extremes, and it's probably going to be a case-by-case management issue. I don't know what the experience is with my colleagues.
Yes, I think this is extremely important, and that's why it's we need an assessment, independent assessment on the first consultation. I think a knowledgeable witness, a caregiver, plays an important role because sometimes the patient, lose a little bit the judgment about his own condition. So by matching actually what the caregiver reports with what the patient feels, I think we have much more accurate assessment of the entire problematic, and we can somehow manage the case much better with this information in hands. So in our clinic, we always require a presence of a partner during the first consultation, and I think this is extremely important. And the lack of judgment happens because the areas of the brain that are associated with social cognition and also judgment are affected earlier than we think. And for some specific cases, this can be even the first very sign of a dementing disease.
If I can bring something positive, is that even if the person does not recognize that they might be experiencing difficulties, when we present to them some results and we say, I have something to help you for it not to get worse over time, can maintain function for some time, they are rarely against the idea of receiving treatment, even though they do not recognize some of their difficulties and deficits they are having, with the idea that it will enable them to remain functional a little longer, as mentioned by Dr. Gauthier.
As a former care partner and having a mother who had the anosognosia, I really, when I work now with family members, I really recommend that if possible, what Dr. Rosa-Neto, what you were saying, if they could either send ahead of time their list of concerns, like have a pre-appointment call with a clinician. It's so difficult to be sitting with a family member who doesn't recognize that there's anything wrong and trying to talk about them while they're sitting next to you. It is so uncomfortable, and I hope that more and more in clinics, memory clinics, that they will really consider, having either a separate room for a family member could come and talk, or doing a pre-intake the day before the appointment. But to sit with and talk in front of a person where they don't recognize that anything's wrong is so incredibly difficult. Mm. So I'm being careful of time, sensitive of time. I have because the last question for me is going to be very important. But we get a lot of questions relating to medical assistance in dying. I must say that I will be doing a webcast on this topic in the next month or two, so stay tuned for that. But in the meantime, Dr. Gauthier, can you please provide an update on the Quebec National Assembly's Bill 11 and explain how people with dementia can advance requests?
Pleasure. This was fun reading. I read it twice. So Bill 11 is changes to the existing law that would allow people who have an early diagnosis of a dementing condition to make their choices ahead of time. So what I brought out as a positive things for our audience is that specialized nurse practitioners will be allowed, like physicians, to provide MAID and to issue death certificates. The other good thing is that Alzheimer's disease and similar disorders, which we call as a group neurocognitive disorders, is not equivalent to mental disorder, because mental disorder is not currently in the spectrum of MAID. whereas Alzheimer's disease is recognized as a serious and incurable illness from the point of view of the law. And this allows you to ask for MAID ahead of time. The big issue still remains, and it's not yet written down in Bill 11, it's something under discussion, is the person who would have a diagnosis and now had some education about the disease, they have a 10-year ahead of them, they would have to clarify the level of what they call physical and psychological suffering, at which point they wish to have MAID, even if they're no longer competent. And this has to be made practical because the doctor you're talking to now and the notary and the witness, probably two witnesses, in 10 years, they'll have the document and it has to be usable. So I'll be aware that in 5 or 10 years, it will be a different doctor, a different treatment team, maybe a nurse that will need to have what they call objectable evidence that the stage of disease you've selected, you've reached that stage. So this requires further work. There will be a minimum of 2 healthcare professionals who will certify that yes, you have reached that stage. And you will decide ahead of time who you trust to be the so-called third party person. And you may be allowed to have 2 of them in case, let's say your daughter at the last minute doesn't want to go through with it, but there's a backup person who's aware of your wishes. So as you see, it's not that simple, but the principle is set. We were at a conference last week, Claire and I, the Canadian Conference on Dementia, and we had our usual update on MAID across Canada, and everybody's looking at Quebec because we're the leaders in that field. So that's it for Bill 11.
Yeah, and actually from that conference, Professor Jocelyn Downey, who made that presentation, will be a guest on McGill Cares coming up, and a real expert across the country on that topic. All right, so my last question, this is for all of you, is regarding prevention strategies. You know, dementia obviously is one of the most feared diseases now, and everybody's trying to understand what can we do to prevent it. So let's go around. I'll start with Dr. Rosa-Neto. What are your top recommendations to prevent dementia?
Right. So most of these dementing diseases are caused by basically 2 reasons. The first reason is a problem related to the circulation. The blood doesn't arrive to the brain in enough quantities to keep the brain working. And the second that encompasses various diseases is proteins that expire and they keep accumulating in the brain instead of being cleared. So this is what happens with Alzheimer's disease. So Alzheimer's disease, we have a progressive accumulation of 2 proteins. One is a protein called amyloid and another is called tau. So these proteins, they exist in the normal system, but they are normally cleared in a very efficient way. In patients with Alzheimer's disease, this accumulates, and at some point they become toxic and they will cause the disease. So exercise, physical exercise, is extremely important because when you do the exercise, you increase the body circulation, and because the head is attached to the body, we also have an effect on the circulation at the level of the brain. So this helps actually the clearance system to get rid of these bad proteins. And I think this is an extremely important. This keep moving. As I learned from Dr. Gauthier, what's good for the heart is good for the brain, and he's absolutely right. So I think this is important. Of course, you know, nutrition plays an important role. I think this is extremely important. Take care of basic medical conditions like risk factors for cerebrovascular disease, high cholesterol. Make sure that the diabetes for the people who have diabetes is well controlled, and high blood pressure, which is important. Cardiovascular effect that increase dramatically the risk of developing dementia. Of course, you know, there are other risk factors that are extremely important, but I'll let my colleagues actually to share their knowledge as well.
All right, Dr. Morais?
If I may add, everything has been said in terms of cardiovascular risk control, but it is also more and more recognized that the position of these abnormal proteins also engender a lot of inflammatory reaction locally. And maybe one of preventive measures is to have a diet rich in antioxidants. And there is evidence to the effect that adopting certain diets of healthy eating habits, patterns of diets such as the Mediterranean diet or a DASH diet with very little salt and more contributes to control to a certain extent the amount of inflammation that can occur by these abnormal depositions. So we give the maximum help to prevent the disease progression by adopting good lifestyles, exercise, vascular risk factors control, and also good healthy diet. How about stimulation to the brain, Dr. Gauthier? Stimulation, so many kinds of games and challenges.
Good point. I was going to mention bridge, which my wife is training me for. So I'll just add to the prevention strategy, and that's the most helpful message we can have as a group today. Prevention actually works. Before the pandemic, there were less people with dementia in Ontario than expected, because they were very aggressive for stroke risk factors, and stroke was handled as aggressive attack. And it's the same pre-pandemic in the UK, some parts of the UK and Scandinavia. So I think if we control the vascular risk factors, and I think the baby boomers as a group, we've done that well, better than our parents and grandparents. So we will probably live longer and probably have symptoms later than our parents and grandparents. So now what more can we do? If you're hard hearing, it's now in the list of 12 items that can be modified. Social isolation. It's better to be in a book club than to read alone. Okay. High alcohol. We've been drinking too much since the pandemic. I'm cutting down 1 glass a day. No more 2 glasses a day. Brain injury. Hello, wear a helmet if you go on a bicycle in Montreal. And please don't hit the pedestrians. So some things can be improved in our environment. Some things are more depending on your own medical history. The 12 preventable risk factors is something we should be aware of. It's part of what we teach in the Dementia Education Program. It's part of the Lancet Commission. There's some new ones coming up. Sleep disturbances, so slow wave sleep, we need to improve that. It's probably one of the major ones that we have to work on now. Impaired oral health. So there's some bugs in our gums that probably got into the brain, and it's something even in later stage of disease that we can still work on. COVID-19, long COVID, it's a total wild card. We have no idea what it will do to the brain. Stay tuned.
And the 2023 World Alzheimer's Report, which is available on our website, has an entire focus this year on risk reduction and prevention. I'm so fortunate to be working with all of you, and I hope that I was able to provide our viewers with a really good overview that the McGill University Dementia Education Program is so much more. I mean, McGill Cares to celebrate our 100th episode, but we have such a comprehensive range of free resources. This is our leadership team in front of all of you. And just to let our viewers know that our program is 100% dependent on private donations. Everything that we've been able to accomplish is really thanks to the generosity of so, and we hope that we'd be able to count some of our viewers as donors as well, so that we can keep doing the work that we're doing and support and educate the people that need it. So thank you very much for watching today. Gentlemen, thank you for joining me. I look forward to another 100 episodes of McGill Cares. And thanks again. If for those of you again watching, please go to mcgill.ca/dementia to find out about all of our comprehensive resources. You can also find the link to make a donation to our program. You can find the link to also to subscribe to our newsletter to find out about all upcoming episodes of McGill Cares and other initiatives that we have. So thank you for watching, everyone.
Bye, everyone.